Great. I'm Fred Nicholls. I'm from the University of Calgary. I'm going to talk to you guys a little bit about some of the things that I think about when I'm trying to pick my levels when I'm correcting deformity. And so by the end of this talk, I hope that you have some appreciation of some of the considerations, the biomechanical considerations, clinical factors, and the contribution of striving towards normal alignment. So we'll start at the bottom. Bottom is a little bit simpler. And in general, if to correct the deformity, I need to stop below L4, I like to take things all the way down to the pelvis. Pelvis gives you a nice strong base, and fixation of the pelvis can help prevent against sacral insufficiency fractures and against pseudoarthrosis at L5S1. It also can help give you adequate caudal points of fixation if you're doing a 3-column osteotomy. In some situations, especially with ankylosing spondylitis, you can sometimes get away with it with a higher 3-column osteotomy than at L4. But when you are going to a lower osteotomy, it's very important to get those extra points of caudal fixation. The pelvis can provide for that. More so than whether or not to stop at the pelvis, I think it's much more interesting to talk about how much fixation you're going to try and get there. And as we move from unilateral pelvic fixation to bilateral, from single bolts to dual bolts, from using connectors to going to direct, you get a little bit more fixation each time. And if you're not careful, if you're just doing a poly connector to a single poly screw to a single rod, the only strength you're really adding is the rotational strength of your set screw onto your rod. And so then you can still see failures despite that. And then you can augment to the next level up and start trying to use dual bolts. I think it's always nice to try and leave something for the revision, so I don't necessarily go all the way out with dual monoaxial screws in a quad rod construct to begin with, but you want to leave something to fix it with. Dr. Jones already talked to us a little bit about sacral insufficiency fracture and treating those, and that's where you always want to upgrade to much, much stronger fixation to get that corrected. Here you can see I've used that dual pelvic fixation with the rods running directly into them and a mix of monoaxial and polyaxial screws. So once you've got your base, you need to start thinking about what you're going to do above that and how you're going to correct your deformity and what you want to correct it to. And that's where we start trying to think of how we define an appropriate correction and define normal alignment. And in general, we talk about these two different schools of thought with the Schwab criteria for adequate correction and the Roussely morphotypes. And so your Schwab criteria are all based off of achieving your minimal clinically important difference in your correction, whereas your Roussely morphotypes are a more subjective description of the overall shape of the spine, separated out by pelvic incidence and apices of lordosis and transitions from lordosis to kyphosis or inflection points. And so neither of these is totally correct, and neither of these is totally wrong. And if we look only at the Schwab criteria and we're shooting for MCID, and especially when you start thinking about like age-adjusted goals for realignment, you have to question yourself, is this something that's reasonably applicable to everybody in a certain age group, or is it just that our goals are being set by the activity goals of that subset of the population? Is it normal for somebody that's 75 to be forward, or do they just tolerate having less energy efficient posture when they're walking? And so what normal is can be a little bit difficult to define, and even Roussely's morphotypes keep changing their characterization, and there's little adjustments that keep creeping up in the literature. And so when we look at the distribution that Roussely originally described, we can see that the vast majority are type 3 with 46%, and then another 42% made up from type 2 and type 4 with a very rare type 1. And the little red numbers below that are at the University of Calgary. We've developed a very large database of normative patients healthy volunteers from the community that we're tracking in a prospective fashion to look at their alignment and changes thereof, we've been able to really confirm that distribution that Bruce Lee originally identified, and also the rarity of type 1. But that doesn't mean that we can ignore them. So when we look at the means that lead to achieving minimal clinically important difference, we can see that the type 3 morphotype is really what drives that. However, when we move to the different morphotypes, it changes how much lordosis we want in some sections, where the apex of that lordosis is, and where the transitions are from kyphosis to lordosis. And this is really important when we want to understand the moments that are running through the levels where we want to stop our instrumentation. This is Beltonneau's biomechanical construct. And when we think about the moment that's running at the apex of lordosis, much larger than the moment that's running at the inflection point from lordosis to kyphosis. And theoretically then, stopping closer to the inflection point will help us with prevention of having too much of a moment over that transition from a very rigid construct to a mobile construct and perpetuating a junctional failure. Those inflection points are generally located in the upper thoracic and in the lower thoracic spine. So, I mean, you can make the argument, maybe you just stop at T4 or at T10, and for a long time, that's exactly what we did. Although we are starting to get a little bit more granular. And if you think about the inflection point in a type 1, from that lordosis in the lumbar spine up to the kyphosis, it tends to be lower and around L2, whereas for a type 4 patient with a high lumbar lordosis and a high apex, you end up with an inflection point closer to T11. If, to correct your deformity, you can't stop close to that inflection point, I usually like to carry my instrumentation up to the next one, where I can get a little bit more neutrality. Now, unfortunately, there's no perfection there, because even if you do stop close to it, like there's a reason that picture B ended up being taken. So the intercalary levels matter as well. How you set your apex of lordosis matters. As you raise the apex of lordosis, you end up getting more tilt at the inflection point. And somebody brought up Dr. Lewis's paper, I think it was Yashar that brought that up earlier, that then you end up with more tilt, and they have bigger kyphotic moment over the top of it, and patients need to adjust with a little bit more pelvic tilt at the bottom. Now, that posture may be normal in higher morphotypes, but it's really not normal in lower morphotypes. So if you cannot bring your apex of lordosis to where you need to be, then you should consider going up to the next inflection point up to have more of a safe zone. When you're planning to try and stop low, you need to think, is there still a deformity in the thoracic spine that I need to correct? And if you do, then you should probably include the thoracic spine in your construct. With a sagittal plane only deformity, you can often get away with stopping just in the lower thoracic spine and still achieve the correction that you need. But with a biplanar deformity, or especially with degenerated idiopathic scolies, they often have a rigid thoracic curve that requires your attention as well. It can be really challenging to predict the amount of compensation that's going to occur in the thoracic spine after you've made a big correction in the lumbar spine. And you can see in this case that the thoracic spine stayed fairly rigid, despite all indicators suggesting that it would have mobilized and we would have gotten a little bit more kyphosis and maybe taken out a little bit of the hyperextension through the hips. On the other hand, if you have a very rigid thoracic spine, like in a case that's been fused in this patient when they were a teenager, you can either plan to bridge the entirety, or if you can get enough adequate points of fixation low down, you can often hold your correction with just stopping kind of quote unquote low. The last thing I like to think about is having that little bit of a transition, Cliff spoke earlier about having a softer landing with his rod materials. And instead, because I like to do a lot of front back surgery and I have a lot of anterior support, I like to leave at least one, but preferably two open disc spaces right at the top to give a little bit more play at the top of the rods and a little bit of a smoother transition there. Ultimately, what you're looking at doing is trying to achieve neutral force at your UIV to UIV +1. And you can see that if you can predict the way the spine is going to move after you've finished your construct, you should see neutralization of the disc spaces above. That's important sagittally, and it's also important coronally. And so you won't always get everything to be completely neutral in the coronal plane, especially if there's somebody with more than one coronal plane curve, like a double major curve. You're not going to necessarily normalize the coronal end plates completely. However, if you are seeing that change so that they're less acutely angled, you can tell that you've probably gotten your level right. On the other hand, with your axial rotation, it's very challenging to change the rotational alignment in an adult patient, unlike in a young patient or a young adult patient where you can still do some derotation. The disc spaces tend to be really rigid. And so I try and always stop somewhere where the rotation is neutral. Predicting correction is challenging. And, we saw earlier with Dr. Kent, he had some really, really nice preoperative planning software, and he could see exactly what he was doing at a segmental level. And that may be true when you're putting your interbody in, you can predict what that individual disc space is going to look like, but predicting what the disc spaces around it look like is more difficult. And right now, I feel that that's an area that preoperative planning software falls a little bit short. We don't necessarily see what we're going to get there. And preoperative planning software, as you can see, can make it look like you can do anything. And at the end of the day, whether we were going to be able to stop at L4 or if we were going to have to take things much, much lower is difficult to visualize. And often you end up having to make the decision on the table. The other thing that's important is that often our wait lists are very long. And when you're basing your decision-making for surgery off of your initial films, by the time they get onto the table, a lot has changed. And so, I can't remember who said it earlier about in the past doing things in a stage fashion and no longer doing it. I really like doing things in a stage fashion because I can put my interbodies in, I can get my patient up and moving around. I know if we've gotten enough decompression from the indirect decompression from the interbodies, and I also get a rough understanding of whether or not I'm going to be able to stop low or if I'm going to have to go high. And so in a big sagittal plane problem like this, after the interbodies are in, we can see that we've got a big correction. There's no need necessarily to take things all the way into the upper thoracic spine. That's even more true in a coronal sense. When there's a second curve, I find that it's difficult to know if that thoracic curve is going to correct, how stiff it's going to be, until after I've done a little bit of work. And if I see a little bit of correction after the interbodies, I can be reasonably sure that that's going to remain mobile afterwards, and I can reasonably stop low. There are patient factors that contribute to our decision-making on whether or not to go high or to go low. Patients' lifestyle demands can make it seem far more ideal to stop low. They can be more mobile, participate in more activities. But ultimately, if you think that you need to go high to get an appropriate correction, you shouldn't compromise. That's a discussion you need to have with your patient when they're ready to let you go high, when you're no longer taking any of their desired activities away from them. Then they're going to have a better outcome at the end of the day. I think back to a patient where at the end of our discussion, he said, well, how much am I going to be able to do after this? And I said, well, you probably won't be mogul skiing. And he's like, well, I want to be mogul skiing. I said, well, maybe it's time to hold off on this surgery for now. And it's been 3-4 years, and he has not returned. But we'll see what happens. Bone health, on the other hand, can lead you to want to put in more screws, but on the flip side, you should be thinking, maybe I should optimize the bone health instead of just putting in more screws and more cement like I did in this case. And the last thing is, if you're considering that a patient might be too frail to go all the way into the upper thoracic spine, you should be thinking, is this patient too frail to have any surgery at all? There's a lot of advantages to going up to the upper thoracic spine. You don't have to worry as much about the intercalary segments. It's more forgiving. You have more room to get the correction that you want. You have more points of fixation. But patients really, really don't like it. They have difficulties with perineal hygiene. They have difficulties putting their shoes on and socks on. And they have difficulty caring for their feet or doing activities down on the ground or on their knees. So at the end of the day, is there a perfect algorithm? There is not. You need to really have all of these things in mind and at the same time figure out what you yourself achieve when you use the individual techniques that you choose to use. Because what Jens achieves with his intradiscal osteotomy or with a T-lift may not be what you achieve with a T-lift. And what Yashar gets with a big A-lift at 5'1" may not be what you're able to do. And so planning your cases based on what you can get with each of your techniques is far more important than using planning software to show, Dr. Lewis's PSO versus my PSO. Once you're done with all of that planning, though, eventually you just got to shoot your shot, and over time you'll figure out what you're getting and what you're not. Thanks.
Well, thank you so much for that talk, and thank you for coming. I think this is probably one of the most challenging things we deal with as spine surgeons doing deformity surgery. And I was just wondering, over time, are there any things that have really kind of pushed you? I think one of the points you brought up, I think cannot be understated. What is the lifestyle expectancy? Making people understand what having a high thoracic fusion will do to their lifestyle limitations is very challenging for someone who's never experienced it. What are some of the things that you've seen in your years of treating deformity that have kind of gotten through to patients and been able to make them understand that a little better?
I'm not sure it's easy to explain to somebody what it's like to be totally rigid ahead of time. Instead, I try and get a feel for what they want to do in a typical day. And so, somebody that wants to do a lot of gardening, for example, or wants to be down on their knees for most of the day is probably not somebody that's going to be overly happy being fused all the way up. Whereas somebody that wants to go for brunch, feed some pigeons, and come home is probably going to do it. Like Jens is laughing, but we all have patients like that, right? Like if they can go to the park, if they can see the grandkids, they're happy, and that's somebody that's going to be a lot happier with it. I mean, I know I showed a bunch of cases that go up high, but overwhelmingly, most of my cases end up stopping in the lower thoracic spine. We see a lot of golfers and active elderly patients. And when you start saying, well, you're going to add like 30 or 40 strokes to your game with an endpoint at the lower thoracic spine, let alone at the upper thoracic spine, they tend to favor the lower. Yeah.
Thank you. Is that for 9 holes?
Yeah. Listen, they still beat me, but
Thanks, Fred. That was an excellent overview, and I appreciate you coming. I just want to clarify on the inflection point, because I probably would never stop at an inflection point. I think the shear levels are the highest at that level. I was just wondering, maybe I didn't fully understand what your relation of your upper instrumented level to your inflection point.
Yeah, so I really So when we're looking at the inflection point here, right, you're not seeing that big kyphotic moment that you have at the apex. This is simply my experience. These are the things that I think about. I find if I stop too close to the apex, you have a big kyphotic moment trying to take you back to that plumb line. Whereas if you stop at the inflection point and things are neutral, like the next level up just kind of wants to sit even on it. You disagree?
Yeah, fully.
You fully disagree. Okay.
But I think maybe you guys are saying different things in terms of inflection point, right? So you're talking more about the inflection from lordosis to kyphosis, right? Versus stopping at the apex of the kyphosis, which we would never do.
No, I think we're talking about the same thing. We're just very much disagreeing on it. You know, I think that's reflective of the fact that there isn't a proper algorithm for
So
this.
Steve, I'm interested because the inflection points are usually T10. Okay. I'm interested because the usual inflection points for the average person with, again, like type 3 Roussel, the inflection points are usually T10 or T11 and up at T3 or T4 are the two areas where you have the inflection points. And that's usually the most common stopping point. So where do you stop?
First of all, I don't agree that T10 is the inflection point. I think the most common, it's T12 or L1. And so I think at T10, you're above the inflection point. And you can see, you know, when you do your T10 to pelvis, you're always bending kyphosis from T12 to T10 because you're above the inflection point. Because the inflection point is usually at the T12, L1 level.
So do you stop at L1 and T12 most commonly for?
Never, because
Okay.
that's when they're going to fail.
I
In my
almost
hands,
always
there are
stop at T12.
Yeah. So when I looked at my results, and that was, I had about a 75% upper instrumented fracture stopping at T12 and L1. And that went down to, you know, probably insignificant fractures of about 30%. So for me, I think the inflection point is T12, L1. I do not feel it's as high as you're saying in the majority of the patients. Only in the Roussel 4s are you going to see it at T10. The majority of the patients are going to be low. And then, so I'm always bending, going up to T10, and I'm putting in a nice little amount of kyphosis between T12 and T10 to really aim and settle that down. I think the shear lows are so high at a very oblique disc face, and we published our results that they showed the picture of, and that was where the results I published on about a 75%. Most of them were PSOs, let's say at L3, because that's what we were taught, and we had a very high L1 angle, and those things always collapsed. And I think that's, for me, one of the main points. I think I'm above the inflection point at T10, I'm not at it.
I'm very much not disagreeing with you on the angle, but I think the angle is unique to different people. And if you can't get their angle where it's supposed to be, whether it, you know, some patients it's low and some patients it's high, and if you have it at an abnormal level, then you're adding strain there because you're carrying the levels above either in front of or behind where their plumb line wants to be. And if you're changing where their center of mass is, you're letting more force run through that level. I get what you're saying. If you dial in kyphosis above, then you're bridging the inflection point and you're moving to that next kind of transition into kyphosis. Whereas I don't know that, like, you've done far more of these than I have. I'm only 10 years in it, but I almost always stop around T12 or T11 or with my morph type 1s down at L2. And when I've stuck with that, I've seen less junctional fractures.
Well, I think one of the most important components is how much upper arc lordosis you have. And the higher the upper arc is usually a reflection of too much, too low lower arc. And I think that is going to be one of your components that is going to show it the most.
Kind of what I was insinuating here.
And so, you know, if you have a very high angle at the top, and it's because you're trying to make up for too little lordosis between 4 and 1. Okay. I think we can talk about this forever. It's like the stopping at L3 and L4 in the pediatric world. And so let's thank you very much, Fred. It was really interesting. And then we'll move on with the left.
So next up we have Dr. Nicholls, theologist from